Everyone to this week's COVID-19 vaccination building global capacity learning session focused on microplanning and supportive supervision. Next slide. My name's Bruce Strumminger, and I'm going to be the first person to welcome you today and run through a few logistic items. We have interpretation in French and Spanish available. Just go down to the bottom right of your Zoom toolbar and click on the interpretation icon, a little globe, and you'll see both languages available, as well as an option to mute original audio if you don't want to hear the original audio in the background. Next slide. Great. Next slide. We really look forward to your questions and comments about today's session. So please put those in the Q&A feature, and we'll be monitoring that and hope to get to as many of them as we're able. The questions we're not able to answer live today will be answered in writing and shared later. If you've got any logistic questions or questions about the certificate of attendance, please put those in the chat and we'll respond to those there. Next slide. This session is being recorded, as all the sessions in this series have, and your attendance is consent to be recorded. We'll be sharing the recordings in English, in French, and Spanish on the TechNet 21 website, as well as on a website specifically for this learning series, and we'll share a link to that in the chat. A certificate of attendance will also be available through the University of New Mexico, where Project ECHO is based, via a link in the chat at the end of the session. And you'll have up to 48 hours to complete a very brief survey. We really appreciate your feedback, and you'll get your certificate electronically immediately after finishing that. Next slide. Just a note about data use. We take data stewardship very seriously and want to ensure everyone that your individual data will be de-identified and kept confidential. Next slide. Just a reminder that this live learning series is building on the COVID-19 vaccination Open WHO online training opportunities. One focused on orientation to national deployment and vaccination planning. That's the same series that today's session is complementing. There's also an online series specifically for training for health workers, and we'll share those links in the chat as well. Next slide. It's now my pleasure to hand the microphone over to Shoshana Golden at WHO. Shoshana.
Thank you so much, Bruce, and welcome everyone to today's session. Next slide, please. As always, we'll start with a few announcements. Today, we're announcing a couple of items. First, that WHO's emergency use listing has updated the recommendation for the Pfizer vaccine to include storage at -25 degrees Celsius to -15 degrees Celsius for up to 2 weeks. After this point, the vaccine cannot be returned to ultra-low temperatures, and it must be used. This change in storage requirements does allow more flexibility for the deployment and the use of this vaccine. WHO product information and other labeling materials, as well as a number of training resources and information products, are being updated now to ensure ease of use with these new recommendations. I'd also like to draw your attention to the COVID-19 vaccine post-introduction evaluation. This is a tool to help countries learn from their experiences introducing this vaccine. We'll be having slides and recordings of a webinar that we held last week, and we'll be adding those to the COVID-19 vaccine introduction toolkit shortly. Finally, I'd like to point your attention to an update to the guidance provided on considerations for optimizing use of the AstraZeneca vaccines. This guidance was updated on the 30th of April and is available at the link below and will shortly be added to the toolkit. Next slide, please. Our topic today will focus on microplanning and supportive supervision, and we'd like to draw your attention to the Supportive Supervision Workshop Series that our partner Boost is hosting with John Snow Incorporated, also known as JSI, and the Immunization Academy. It's a 4-part webinar series that began on the 20th of April, but there are still sessions left, including one that will occur later today. You can feel free to register here using the link available on this slide. Next slide, please. In addition, we have a number of useful resources that might be helpful for you as you go through this session and beyond. WHO has developed a supportive supervision checklist that we'll be hearing more about today, and you can access that resource using the link on this slide. All slides will be shared out after the session. In addition, as Bruce pointed out, there's a number of resources, including the COVID-19 vaccination training for health workers, that focuses on resources and job aids for vaccinators and their supervisors. There's simulation exercises to help vaccinators and their supervisors prepare for vaccination, including communication, supply and logistics, vaccine safety, and regulatory aspects. There's also training on how to use these vaccine simulation exercises if this is new to you. We also have a number of other resources, including a COVID-19 vaccine checklist for frontline health workers who are planning a COVID-19 vaccination session. Next slide, please. I'll now talk you through today's agenda. We'll start by a brief overview of microplanning, followed by a regional example from our colleagues in Afro, a deep dive into the Ghana experience, and then an overview of supportive supervision. As always, we'll conclude with what's next and questions and answers. Next slide, please. Our goal for today's session is to provide an overview of the key information that countries need to know when they're conducting COVID-19 vaccination microplanning and rollout. We have 2 learning objectives. The first is to provide examples of microplanning experiences and lessons learned so far. Our second objective is to share an overview of the value and the tools available for virtual supportive supervision. Next slide, please. With that, I'd like to turn over to Diana to walk us through microplanning.
So hello, everybody. I'm Diana Chang-Blank from WHO, and I have 2 very short slides just to set some context. But the details on microplanning will actually be covered in the following slide. Next. So just to say that I think many of you should be aware of the National Deployment and Vaccination Plan, the NDVP, which was developed by WHO and UNICEF back in November. And this is a really high-level national strategic plan. And it's currently undergoing an update to have more information that was not available to us back in November around the different COVID-19 vaccines. And this NDVP has provided the framework for over 100 countries to develop their strategic plans around COVID-19 vaccine introduction rollout. Now we have multiple COVID-19 vaccine products that have been EUL'd by WHO. So we're increasingly getting questions about the operational components and the operational rollout to those vaccines and how a country can approach that. So there is a need for an operational guidance to the microplanning, which would be a complement to the NDVP. Next. So certain countries, because of the rapidity of the rollout, certain regions, pardon me, have already developed some operational guidance materials based on their experiences with current immunization programming and adapted or updated those plans. So you see on the right here, an operational field guide from AFRA, which the next speaker will speak to, as well as COVID-19 service delivery modalities from Euro. And then PAHO has also developed materials, and in particular, a self-learning training that'll be available in Spanish, French, Portuguese, and English. I've put the website at the bottom of the slide deck, and currently that has 2 modules on how to prioritize populations and developing microplanning. So in complement to these regionally specific operational field guides, WHO HQ is developing a complementary module to the NDVP around the implementation for longer term COVID-19 programming. So on the assumption that this is a public health issue that will remain with us for quite some time, as the COVID-19 vaccines become more integrated into an immunization program, what are the considerations and the kind of nuts and bolts that need to be taken into consideration. So we will develop this module and complement to and in coordination with our colleagues who work on digital microplanning for equitable access and delivery of COVID-19 vaccines. And so this is around using GIS mapping or different technologies we have available to identify and develop strategies for target populations. And I think that's my last slide before we move on right into the content from our African colleagues.
Thank you, Diana. We'll now go over to Meseret to learn about the Afro-regional experience.
Thank you, Shoshana. Colleagues, welcome to the webinar. I'll provide the Afro-regional overview. I'm based in Zimbabwe, working for the sub-region, WHO, Intercountry for East and Southern Africa. So to provide the overview of the microplanning in the region, in the African region, we have used the experiences from the polio eradication initiative, the accelerated disease control program, new vaccine, multiple introductions, which help us to inform the development of the microplanning tool of the field guide for the operational guide that we have developed. Numerous examples have been used. For routine immunization, we use the Reach Every District, which is casted to reach every community. But as you know, we usually take time before new vaccine introduced, at least minimum 6 months to a year. But the COVID pandemic has not allowed us to have that time. So although the tool was there, the utilization by countries has been variable. So the regional level developed this guide to help operationalize the national development of vaccination plan from the macro plans, from the bigger plan into micro plans. And it's the essential tool for the COVID-19 vaccine rollout. On the right side, you could see the macro plans from the NDVP. Who will pay for the activity? Who will provide the training? How is our logistics to work? What's our procurement distribution plan? How will we reach the hard-to-reach communities? How will we communicate about this vaccine? What is the timeline for the various activities? What is our specific target population for each phase? So this national level macro plan in the NDVP was translated to operations using the essential tool, what we call micro planning. Next slide, please. So translating this plan through the micro plan into operations at the health facility, which is consolidated to district level. It was used by health facility, catchment area. It has helped us to identify or reach the intended prioritized target population for the different phases to ensure the necessary inputs and resources also are delivered to the right place in the right amount. That's the purpose of the microplan. And also mapping the local needs against the local resources that are required. It was also accompanied in some of the advanced countries with sketch maps to indicate who is going to vaccinate where, what are the clear boundaries between districts, between health facilities. So settlements and catchment areas were very well defined. important landmarks, the vaccination depots as a source of vaccine, the vaccination posts were also really identified. So this is a snapshot on the right that you see from our guide at the health facility or district level with the important parameters highlighted there. Next slide, please. So the microplan tools has clarified the operational level needs to ensure equitable distribution and delivery of vaccines so that we don't leave any prioritized target population for that phase of vaccination. So it has helped us. Who is targeted? The target population by phases of implementation and by administrative unit. What the bundled vaccines and supply needed. It included the infection prevention control supplies, the tools, the documentation tools, AAFI kits to be there in each vaccination areas, center, the cold chain space that was needed, and the who would do the vaccination, identifying the human resources needs. And it even helped our countries where team members were not enough. They re-recruited, brought back the experienced retired nurses in some areas. Supervisors, mobilizers were very well identified, where you could see on the right side, detail of the resources required were identified by the countries. The catchment area, the selection of the service delivery sites. Are we going to call them to come here? Are we going to go with a mobile strategy to reach our communities? When is the date of service delivery? At health facility level, that was communicated clearly. The daily movement among the vaccination team with no overlap has been very well delineated by some of the countries. The number of vehicles, health workers they required, the volunteers, announcement, message media, what type of medium for messages were going to be used, how much the cost was, the rental, the fuel costs, etc. Of course, some of our countries may have suffered operationalizing it the best way because of limited funding at the operational level to mount or to raise the required number of supervisors as we used to for any new vaccine introduction. Next slide, please. So the tools have allowed us capturing estimates at the operational level according to the standard set. Remember, equitable vaccine distribution for the targeted by each country. So the detailed map or population, health facilities, schools, distances, where they were designated as vaccination centers were required, some of the information required for the completion of the microplanning exercise. The population data by district, urban, rural, and also certain specific populations so that we don't call them minorities and they are neglected. They could be internally displaced populations, migrants, refugees, all of them have to be listed within the district and the catchment. The list and description of the underserved or special populations. Of course, the cold chain inventory, waste disposal facilities, adhering to the specific vaccine that we were receiving. The transport inventory, as I have already stated, the required health workers and volunteers. Financial resources from all sources also. It helped also the identification of the required resources to the details. The list of community leaders, our potential partners, were also identified. And knowledge, this was informed by the knowledge of the local context. So, of course, we have observed vaccinations being rushed because it is pandemic. Our authorities, senior level ministry leadership cabinets were pushing, just go ahead and vaccinate, you've been vaccinating. But the team in the immunization also know that they have to really adhere to standards. So it's like balancing the urgency versus the vaccine rollout. Pre-listing of healthcare workers for phase 1 was done by many of our countries. So what we observed briefly was the pre-registration, though, was done in some, it worked very well in some countries. And where it did not work well, it was challenge of IT. Printed appointment list did not match with health facility list, etc. Those are teething problems that countries noticed, which they are improving as they move on. But for phase 2 now, our countries are revising. They have learned a lot from the rushed phase 1 introduction, but adjusting to ensure appropriate microplanning guides the service delivery so that we don't miss the targeted population. Next slide, please. So our micro-planning standards, when you see, we have to come with a sort of estimates for vaccine doses. We use target number times wastage factor, the vaccine vials specific to the number of doses that were going to be used. So these were the rough estimates that we put. However, depending on the vaccine that was introduced in the country, this will be adjusted in the next phases. And also the estimated workload and human resource requirement that we put in our guideline. We said in urban centers, probably with the spacing that you do, you can vaccinate about 100, while in the mobile teams, please limit it to minimum of 50 per day, sort of in rural areas. Now, as we move to targeting the elderly who could be also living in urban majority of our countries, targeting guidance was given for mobile teams about 60 per day. So we have really set the standard for them to ensure they conform at least with the minimum standard. So the micro-planning has really helped to set the standard at country level. Next slide, please. So this is an example of a country where they have really used the micro-planning not only to identify, but also to cost the required resources, which is also used for resources mobilization. So it's just an example that we'd like to share with you. And excellent micro-plans have been developed in some of our countries that has really guided the strategies for implementation. Next, I think this should be the last slide. In summary, we have in the African region utilized our country experiences to develop the standard Afro field operational guideline. The micro-plan is our basis in operationalizing the national deployment and vaccination plan, including to address the inequity that we want to prevent. And in observation, some countries did not have adequate time, really. Others had limited funds to support the bottom-up micro-plan development, the ideal micro-plan. And the costed micro-plans have been used to mobilize estimated resources, not only for that, but to address the gaps in service delivery. We also note that rushed implementation of the vaccine rollout, which was really pushed by the highest political leadership. So standard guidelines may not have been followed in the initial launch. But the population groups to be reached can only be identified and reached with the appropriate standard micro-plannings. Thank you.
Wonderful. Thank you so much, Meseret, for that fantastic regional overview. We'll now turn to Fred to provide the Ghana micro-planning experience. Over to you, Fred.
Thank you very much, Tristana. So quickly, colleagues, I'm going to take you through the Ghana micro-planning experience. And next slide. Yeah, so the overall leadership for the COVID-19 vaccination response has been the Interministerial Coordinating Committee, which is chaired by the President of the Republic. Below that committee, there are other committees that were formed to oversee various aspects of the response, including the vaccination response. Through the support of our colleagues at Afro, Wakaro, and HQ, we were able to develop the National Deployment and Vaccination Plan, which is the main strategic document that is guiding the vaccine rollout. And of course, it was the National Deployment and Vaccination Plan that informed the development of micro-plans. Now, Ghana, we have had the opportunity of rolling out a number of vaccination campaigns. So that experience from previous campaigns really guided us. Of course, every campaign is unique. And if you look at COVID-19, I mean, the target is so wide. So the demand of this COVID-19 vaccination rollout was completely different from the other campaigns, but we used that experience to guide us as we moved forward. There were so many questions that came through our mind as we were developing the National Deployment Plan, as well as the operational plans, what we call the micro plans. The COVID-19 vaccines have been developed within a very short period of time, and I believe all of us on this call will attest to the so many conspiracies that were running around, especially on social media. So these were some of the thoughts that guided us as we moved through the micro-planning process. These vaccines are targeting, the non-traditional immunization targets. That is persons 18 years and above. How do we plan to reach such persons? Because ordinarily, the immunization program is looking at under 1s, under 2, under 5, and occasionally we go up to 15 years. But now we had to go beyond the normal or the usual target groups that we deal with. So we needed to think outside the box. Now, what strategies were we going to use to identify and verify persons among the high-risk population segment? What others call prioritization or prioritized groups. And then how do we generate the necessary demand for the vaccine as the misinformation and disinformation continue, especially on social media? Day in and day out, to get people sitting on social media and sending in all sorts of stuff about this vaccine. But we needed to plan, especially our communication subcommittee, to make sure that all these rumors, misinformation, disinformation are addressed so that the necessary demand will be generated for the vaccine. One very key thing that we battled with was the estimating of the population for the segmented population groups. How do you come about with the proportion of persons within your population that have underlying comorbidities? Persons that are within this category, knowing very well that some of them are also cross-cutting. So it makes the target setting so much difficult. And we have a very fluid population, people moving in and out and all of that. How do you plan, especially to get people at the time of the vaccine rollout? So colleagues, if you look on the right pane, what we see on the top, the figure on the very top is the National Deployment and Vaccination Plan that was developed. And then following that, every district developed what we call micro plans. And these plans have the finest details as in operationalizing the whole vaccination rollout. Next slide. Yeah, so we had to, based on the WHO Strategic Advisory Group of Experts and then the National Immunization Technical Advisory Group, we needed to segment our populations according to the risk level, what others call the prioritization group. So for our first group, we considered health workers, frontline security personnel, persons with known underlying medical conditions, persons who are 60 years and above, the frontline members of the executive, legislature, and judiciary, teachers who are more than 50 years, and other essential service providers. Let me state that our segmentation was based on 4 key factors. The very first one is the risk of exposure. Should these people get a vaccine? By the nature of the work people do, how exposed are they to the pathogen? So that was one of the factors we considered. The next was disease severity. Should this population group get an infection? How severe will it be? Then the next is business continuity. We needed to ensure that the structures of the country were protected so that business or as it were, management of the country can continue. And of course, national security. So these were the factors that informed the segmentation of the population. Then we have the group 2, which includes other essential service providers, including the rest of the security agencies. So we have the list there. So when you get the slide, you can take your time and go through it. Then the third group is the rest of the general population. So they have been targeted for the last phase of the response. And colleagues, you all know very well that studies are still ongoing. So once we get data on the safety and efficacy of the vaccine in persons who are less than 18 years and pregnant women, of course, they will be reprioritized and then added to some of the identified groups. Next slide. Yeah, so we needed to really prepare very well for the rollout. Ghana, our plan is broken down into 3 phases, beginning with the first segmented population group, as was shown in the previous slide. The planning process indeed was multi-sectoral at the peripheral level. So we had all agencies, NGOs, and community structures coming together to plan for the vaccination campaign. Of course, when you have the communities owning the rollout, it makes things very easy for us because you get their buy-in. They own the vaccination campaign and then they guide as we roll out the vaccination. We needed to also estimate the personnel that will be required. So that was done as part of the micro-planning and all of them were trained. We used a combination of virtual and in-person approach to train up the identified personnel. Of course, we also made sure that even when there were virtual trainings, we demonstrated, there were illustrations to show how the vaccine should be constituted, how the vaccine should be administered, how many minutes people were expected to sit and wait after receiving the vaccine. So all of these were demonstrated during the trainings. We also estimated the number of vaccines, devices, and other ancillary materials based on the target population. Now, in setting the targets, for health staff, we relied on the MOH number on roll. We were able to get some numbers. The national security, yes, we had some numbers, but of course, they kept changing. We went to the Ghana Statistical Service. Some numbers were provided, but when you go down, you realize it's either underestimated or overestimated. And that had a lot of impact as we rolled out the vaccine. For the presidency, judiciary, and parliament, it was quite straightforward. We were able to get the numbers. But then the target population is far and above these organizations. Now, those in the general population, how do you estimate the population subgroups? How do you do all of these? And that was quite a thorny issue for all of us at the operational level. For advocacy and demand generation, we use proven strategies. Like I said on the very first slide, we have conducted a number of campaigns. So we have a very good database of social data from the communities. So districts, sub-districts were encouraged to use proven strategies in reaching out to the population. In addition to that, there were some engagement at the national level as well as the sub-national level. We engaged organized groups, professional groups, and other groups that shown interest in getting more information about what we were doing as a health service. Proud to the rollout, Ghana implemented the cold chain equipment optimization platform, and that significantly improved the storage capacity, not only at the regional level, but also at the district and operational levels. And that really helped us in accommodating the vaccines that came in. On the right side, the pictures you see there, the very first one on the top is demonstrations during some of the trainings. And the other infographics are to demonstrate how the vaccines were being given. And also these were shared on social media. Some of them were printed out and posted at vantage points just to create the needed demand for the vaccination rollout. Next slide. For the delivery strategies, we made sure that all the designated vaccination centers were known to the population. So on the pictures we see on the right side are some of the infographics that were developed and shared on social media and also announced on radio stations, so that those within the targeted population group will know that these are the areas they should go and get vaccinated. We relied on our usual strategies, that is the static outreach, mobile campouts, and in some instances, we use a combination of different strategies. And where necessary, we needed to re-strategize in order to meet the needs on the ground. For example, if you set up a static post in a community and you realize people are trickling in one by one and the patronage is not that high, what do? You need to rethink, re-strategize, and move out to the people, reach out to them and get them vaccinated. We also set up vaccination teams that were sent to identified institutions, including governments, ministries and agencies, schools, and then persons on national assignment. Then we also employed house-to-house strategy. Indeed, this strategy wasn't part at the planning stage, but as the campaign started and rollout was ongoing, we realized that there was the need to reach out to people in their homes, especially those who were unable to move to the vaccination site for various reasons. Some people, I mean, the very aged, it was difficult for them to move to the vaccination site and get vaccinated. At every vaccination post, we had one vaccinator, sometimes 1 to 2 recorders, depending on the load at the site. We had one mobilizer and a supervisor to oversee the vaccination activities. Now, in order to ascertain that people were indeed within the segmented population groups, we use national IDs to identify those who are above 60 years or 60 and above. And persons with underlying comorbidities, they also had to show some form of proof to enable the health staff, the vaccinators, establish that indeed these persons were within the segmented or the high priority group. This was so because we tried reaching out to the general public. We generated a lot of demand, so everyone was trying to queue and benefit from the vaccine. So we needed to some way, somehow, make sure that people came in with an identification so we can be able to know who is due and who is not due. And indeed, those who were not vaccinated were counseled and were made to understand that this is a phased introduction, and when the time is right, they will also have access to the vaccine. In order to ensure that we had a very good, robust database of all vaccinees, we decided to use electronic data collection for the vaccine rollout. And we use the e-tracker model in the DHIS2, as well as ODK. And both of these data collection tools had offline functions. So if you happen to be in an area where internet connectivity is not very stable, you could still use these two systems to collect data. That notwithstanding, we realized that the process was really slowing down because it took some time for people to be registered before they went ahead and took the vaccine. So we introduced what we call the vaccine app. This app makes it possible for people to pre-register. And once you pre-register, you enter all your details using your own cell phone. Now, when you do that, the system will schedule you to go or will give you an appointment stating where and when you should go for your vaccine. And with this, once you get to the vaccination site, your details were already there. So all they needed to do was to vaccinate you and then indicate the batch number of the vaccine that was used. And that made the process quite easier for all involved. Next slide, please. Now, there were some successes And we're also faced with a number of challenges. As most people are now very much aware, Ghana was the first country to receive COVID-19 vaccines through the COVAX facility. And within a short time, we had to plan and deploy. So the campaign was launched on 1st May 2021 by His Excellency, the President of the Republic. And to demonstrate that he had absolute belief in the safety and efficacy of the vaccine, the President took the first jab of the vaccine. The wife, that is the second lady, also took the jab. Then the Vice President and the wife also took turns to have their vaccination. Then on the 2nd of May, that is when the national rollout commenced. And as of now, the country has received a little below 1 million doses of the vaccine, and over, let's say, almost 850,000 persons have been vaccinated. And the vaccine wastage rate is just around 2%, which is quite good. Now, what were some of the key successes? We had very high political support from the presidency to local authorities. So at the national level, we had the president leading the charge. At the regional level, regional ministers were at the forefront, and at the local level, we had traditional leaders and representatives of the president leading the rollout. And there was this sense of ownership going around the country. So it gave people that belief and trust that everything that the health sector was doing was in the interest of the population. Ghana had we have a very good immunization system which provided a platform for the rollout of the COVID-19 vaccine. There was adherence to the COVID-19 prevention protocols. Of course, in as much as we tried vaccinating to prevent people against the vaccine, we needed to make sure that in so doing, the vaccinator, the clients, and the community were protected from being infected with the virus. Aside this, we had challenges. Whilst we continued to roll out the vaccine, there was high-level misinformation and disinformation, especially on social media. So we had to also be responding to them as the vaccination rollout was, or the vaccine rollout was ongoing. I spoke about the target population for the segmented population groups. It was quite difficult because you even find persons with underlying comorbidities being a subset of all the other segmented groups. How do you know that these are the numbers I'm dealing with? And the population, that's in the denominators, had a very good influence on your logistics and every other thing that was needed for the successful rollout of the campaign. And colleagues, I believe you all know the global vaccine supply challenges. As I speak, Ghana is still trying to find its way as to how we can mobilize adequate vaccines for the entire population. Now, what's the way forward? We will continue to advocate and generate demand, even as we wait on the global body to get additional vaccines. We are still relying on the COVAX facility, and we are also exploring other bilateral arrangements so we can get additional vaccines for the rollout. So this is the experience from Ghana. The time given is very limited, but of course, if you need any additional information, you can reach out to me and that will be provided. I'll now hand over to the next presenter. Thank you.
Wonderful. Thank you so much, Fred, for that fantastic presentation. We'll now turn to Jamil for a brief overview of supportive supervision.
Thank you, Shoshana. Next slide, please. My name is Jilmil and I work in WHO headquarters in the API team. So supportive supervision for most of you is not very new. And what we are going to do for supportive supervision for COVID-19 vaccination is not very different, although some methods might need to be adapted. One of the things that might need some adaptation is that you might need to do a combination of remote and on-site supervision. This is because in some places there might be COVID restrictions and it might be difficult to have on-site supervision. But the most important thing is to actually be always in touch with the staff and help them address challenges and problems. So the first thing that you need to do is to actually decide the frequency of supportive supervision visits or the online sessions. And for that, because the vaccine is new and it has quite a few complexities, which my colleagues shared earlier, it's important to have more frequent supportive supervision during the first few months of introduction. And this is really needed because it's important to address problems and find solutions early on, and also to correct practices that are not aligned with the standard protocols. It is especially important to have more sessions in places that have new staff or staff that do not have too much experience giving vaccinations. The other aspect is to always acknowledge the difficult times and compliment staff for their professionalism and what they have been able to do within these difficult times. Also important to listen to them, take notes, and always try to understand what they're going through. And also to ask about their well-being and not just focus on looking at the technical issues. There are now many online WhatsApp groups, and most of the staff now have phones, and those can be used very well for staying connected with the staff and encouraging them to do peer-to-peer learning and messaging in case they have any questions or concerns. And supervisors should also be in touch with staff through these mechanisms and not just rely on on-site supervision visits that we were usually doing for routine vaccination, but to also explore how staff can be better supported with the digital mechanisms. And in that light, if you are planning to do some remote supervision, it's important to kind of test the communication methods like Zoom or Google Meets or WhatsApp, and just be patient, and it works. We've heard from many places that are now using remote supervision using technology. And as my colleagues had shared earlier, there are now many online learning opportunities that can be shared with the staff, as well as look again to digital methods of sharing updates and information through recording your own voice or sharing short messages. Next slide, please. So WHO has developed a supportive supervision checklist for COVID-19 vaccination. As I mentioned earlier, there are aspects that are different for COVID-19 vaccination. So it covers as questions related to microplanning, social mobilization, staff training, as well as on availability of different materials needed for the session. And then questions related to what to observe in terms of IPC measures, their cold chain practices, injection techniques, as well as some questions related to having a discussion and a communication with the vaccination teams. The link is here as well as in the chat, and it will be available. The checklist will be available in all the WHO languages, and the country people are encouraged to actually adapt it to their local situation. Next slide, please. So the next slide shows you a sample of what we have included in the checklist. And as you can see in this part, we are talking about the injection prevention and control measures. And these are very, very particular in terms of COVID-19 vaccination, where one has to check whether the staff are wearing the medical mask, the ventilation is appropriate, there is physical distancing. So all these are included in the checklist. And we created this in collaboration with colleagues in our ITC team. Next slide, please. So the important thing, and this is my final slide, the important thing that I want to stress is that we must encourage supervisors to go beyond the checklist. The checklist is just an aid memoir or a tool to remind supervisors of the main questions or main things that they need to observe during the vaccination session. But the whole session should not be spent in checking boxes on the checklist. It is very important to actually also talk about physical and emotional well-being of the staff. To also recognize that the staff are going through very difficult times. And so questions like how they are feeling, do they feel safe in their job? How are they coping with doing the vaccination and also maybe doing other job responsibilities? And what are their challenges related to that? And do they feel confident in answering questions raised by the community or the vaccine recipients, as they are the first contact that most communities have with the health system? And what kind of support they need from their supervisors and the management? And also ask them what they want to learn more about, what they don't feel confident about, and then how you and other management can support them in their work. So most importantly, supportive supervision should be taken as an opportunity to work together to solve problems, to correct some practices that are not being done very well, and then to provide a safe and effective COVID-19 vaccination. I thank you very much for your attention. Over to you, Shoshana.
Wonderful. Thank you so much, Jamal. I'll speed through the next couple of slides so we can get to some Q&As. Next slide, please. You can find all of the resources for this session and other sessions and opportunities to connect and ask questions on the available links, which will be shared out. Next slide, please. Recordings will be made available in English, French, and Spanish, and they will be shared. We have 3 final sessions for our ECHO series focused on private sector engagement, monitoring and evaluating COVID-19 vaccine introduction, and adaptive leadership. And you can register for those. And we look forward to attending. We'll now use the remainder of our time together to talk through some of the questions that we received on the Q&A feature. I'd like to start off with a question for Diana, Messeret, and Fred. And this question is, what are the main challenges encountered at the operational level for micro-planning, in particular, with regards to non-traditional age groups and targets? Let's start with Fred. You want to talk about those challenges and how you've responded?
Yeah, thank you very much for that question. Yeah, so like I said, it's a big challenge in that this is a population group that is different from the usual target group that the program deals with. For the usual target group, they are laid down strategies that you can follow. If you do this and it doesn't work, you re-strategize and you do the other. Now we are looking at a completely different target group with our health staff on the ground not having any experience in dealing with them. Now, how do you reach out to them? Where do you find them? How are you going to get them to come to the vaccination post? For example, persons with underlying comorbidities, persons who are above 60 years. And in our part of the world, you find a lot of people with these underlying comorbidities also being among those who are 60 years and above. Now, you are going in with estimates of people who are 60 years and above, estimates of persons who have underlying comorbidities. However, there is a big intersection between these two population groups. You will go in there, get a certain number, and you are challenged because you think the number you vaccinated, it is just below your coverage or your targeted performance. How do you rate them? That was why we resorted to community structures, speaking to the community leaders, getting them to advise on how these people should be reached. So in some of the communities, you find what we call the assemblymen in those communities, the chiefs in those communities, joining up and linking up with vaccination teams. And that was when we had to resort to the house-to-house strategy, because you find some people who are in their homes and may not be able to walk to the vaccination site. So these were some of the challenges we faced and how we were able to go around and get persons vaccinated. The approach we are using is not entirely the best, but of course it is currently yielding some results, and we will try and keep refining it till we're able to make it better as we go through the other phases of the rollout. Over.
Wonderful. Thanks, Fred. I'll now turn to Diana to answer a question about identifying unregistered populations, in particular populations that might be migrants or might be refugees, and how to plan for COVID-19 vaccination for these populations.
Yeah, I think that's an excellent question with not an easy answer, which is probably why it's being asked. And it's somewhat linked to what Fred was speaking of before, right? So I think that, this is an area of work that is very untraditional for EPI. So we really have to use untraditional means to try to reach the populations we're trying to reach, including those that are in vulnerable situations, whether they're nomads or migrants or unregistered. So it really requires working with sectors outside of traditional EPI actors, as well as perhaps even outside the sector of the government. It may require working with CSOs or NGOs that are particularly active in that area with humanitarian populations, meeting with perhaps community leaders in that region to try to identify the patterns, the clusters of people, to identify the timing on which they might be available for immunization, their concerns, to be able to then mobilize their demand. So it's really quite a complex exercise, not an easy one. There is an ongoing area of work around trying to, within the COVAX facility, provide vaccines for humanitarian populations. The expectation is most countries should accommodate within their NDVB to reach such vulnerable populations. But in the event that that is not possible for various political reasons or civil unrest, there is what we're calling the humanitarian buffer, where there would be a certain number of limited doses available to countries with which we then can work more closely to find locally adaptable and relevant strategies to reach these groups. Over.
Wonderful. Thank you so much for that response, Diana. I'll ask one more question, knowing we have just 2 minutes left, and all other questions, please feel free to send over in the Q&A feature, and we will collect those and respond to those in a written format. There's a final question from Prashant, who asks about the roles of in-country partners to ensure that microplanning and readiness assessments are consistently performed and are high quality. Meseret, Diana, Fred, can you please respond to how in-country partners can provide assistance?
Yeah, I think I'll take this one. Yeah, so in Ghana, like I said, we have a multi-sectoral committee, and partners in country also regularly meet and advise the government. And we are all parts of the technical working group that is leading the vaccination rollout. Prior to the rollout, we were all collectively completing the readiness assessment, and we developed the National Deployment and Vaccination Plan together. But let me say here that the National Deployment and Vaccination Plan, as well as all the micro plans that were developed, are live documents. They are not cast in stone. They are not documents that when you develop, you have to stick to whatever was put in these plans. As you move along and you realize that there are obstacles that you need to go around in a different way, you revise the micro plans. That's why we always say that micro plans are live documents. So we cannot actually hold the neck of government and say, go by what was written down. No. As we move along, when we realize that some mistakes were made in the plan, we correct and then we change. Whenever new information is received, as in the case of pregnant women and persons under 18 years, the change will be effected and this vulnerable population will be included in the rollout. A case in point in Ghana was the exclusion of refugees in the NDVP. But when this was, our attention was drawn to this, they were included and allocation has been made for them. Also, the UN community and other development partners were left out in a way. But when our attention was drawn to that, we included it in the plan, and up to 800 doses have been made available for the vaccination of UN and development partners in the country. And in any future allocation, the government is going to do that. So, like I said, plans are drawn by the team, but as we roll out and there's need to make any modifications, we go our way and do that. Whilst I have the platform, let me just add one more thing. Somebody wanted to know how we were able to verify persons with underlying comorbidities. Yes, so we either you present a prescription form with your name on it, or you present a medical report. If you're unable to show any of these, then you are advised to seek for your vaccination at your usual clinic where your records are there and you are known to have any of the underlying comorbidities. So that helped us in identifying this group and reaching them out with the vaccine. Thank you.
Wonderful. Thank you so much, Fred, for that fantastic response. And we will be collecting all of the other remaining questions and sharing them out with our experts to provide to you all in a Q&A format after the session. With this, I'd like to give a huge thanks to all who joined us on today's call. A huge thanks to all who presented on today's call. And as always, our fantastic ECHO India and ECHO New Mexico partners and interpreters for their work in making this session so smooth and able to provide all of this content to you so readily. With that, I'd like to wish you a wonderful rest of your day, morning, afternoon, or evening. And I hope you join our next session, which will be in 2 weeks at the same time.